Hello, my name is Einar Ottestad. I'm one of the physicians in the Stanford Pain Management Clinic, and I'm going to talk to you a little bit about interventional pain management for low back pain. And here is my disclosure slide. So my learning objectives, first of all, I want to see who is a candidate for the interventional spine procedures beyond what the primary care physician can do. And then we will cover some of the basic outpatient interventions as well as some of the more advanced surgical interventions specifically for that low back pain problem. And then at the end, I have a few slides on surgery for back pain. So epidemiology, around 80% of the American population has had low back pain at some point in time, and it's second only to the common cold as a cause of disability, and second to headache as a cause of chronic pain problem. And overall, it's the global leading cause of disability, and it's the sixth in global burden of disease. So quite a problem that I'm sure all of us have experienced at some time or another. This will be my main slide on the non-interventional approaches to this benign low back pain problem. And in the table here, we can see more or less the typical recommendations I would have for someone with acute low back pain. Simple things such as bed rest or heat. Actually, heat is able to reduce pain by around 30 points on a 100-point scale in that acute period. Muscle relaxants are also decent with minus 21 points on that scale. And otherwise, massage feels okay. Acupuncture has a 10-point decrease, manual therapy. But overall, my takeaway here is if you lay your hands on the patient and you massage those muscles a little bit, we provide a bit of distraction, and most folks feel pretty good in that acute period of time. Our medications probably aren't that specifically helpful for the disease, although I think muscle relaxers help relax the brain for a few days during the worst part of that acute pain episode. And then for the bit more chronic low back pain, once again, we see our medications. We don't have great results. Minus 8 points on the VAA scale for opioids, and actually less than that for tricyclics. Muscle relaxants and NSAIDs, only minus 3 points on the scale. And then we have our other therapies such as exercise, massage, acupuncture. We're getting to that 7 to 15 point on the scale. And finally, the multidisciplinary type of care, as well as some of our chronic pain interventions we can see on the bottom part of that table. So I do want to cover epidurals, our interventions to target the posterior column of the spine, meaning facet and medial branch blocks. And that'll also include the sacroiliac joint as essentially the largest facet joint in the body. And then I have a few summary slides on regenerative medicine approaches to low back pain. And I'll finish off with some neuromodulation, peripheral and central, before talking about the fusion. So with the lumbar epidural, essentially what we're trying to do is place some local anesthetic and some cortisone, some type of steroid, in the epidural space where presumably we have perhaps a herniated disc here, compressing out the lateral recess and getting the spinal nerve as it exits. We can have arthritis in the actual facet joints and overgrowth, also causing some sort of pinching here. And basically when we have that specific area of stenosis, if we can target that and deliver some cortisone and local anesthetic to that specific nerve, patients do tend to feel better for some, I would say, acute period of time. We have a couple of approaches. Here we see an interlaminar approach where the needle is accessing that spine from the back. So this is the same approach as you would take with a epidural for labor and delivery, for example, except we're giving cortisone instead of the local anesthetic. And this is what's called a transforaminal injection, where the needle is going into the foramen itself, where we want to be a little bit more specific and a little bit more targeted to our delivery of medications. And also here you can see a caudal approach. Once again, we're still targeting that epidural space, and with this caudal approach, sometimes we'll slide in a catheter as well, and using that we can target the epidural space even in people who've had significant spine surgery, as long as the catheter can get to where we want to go. But overall, my takeaway here is when we have these acute herniated discs, we have these acute pinching situations of nerves. If we find those situations when we target them appropriately, we can give patients pretty good short-term relief. So what is the evidence for epidural steroid injections? So what we're seeing here is 2015 pain physician put out this review. So they covered 52 trials looking at epidural injections, and overall found a level 2 evidence for cervical, thoracic, and lumbar. And level 2 is essentially one high quality randomized controlled trial. And level 3 evidence for transforaminal injections throughout both cervical, thoracic, and lumbar regions. Overall, found that these were effective in 50 to 80% of the time. But the key caveat here that we have to remember is they're effective for about 3 weeks after this type of procedure. So maybe 3 weeks is a little bit pessimistic, but in general, when someone has one of these acute herniations, acute onset of radicular low back pain, and we do one of these injections, the patients will generally do pretty good for at least a few weeks. Maybe a month or two, and as we're seeing here, they actually did 2 injections, and sometimes if we get maybe 30–40% benefit with one epidural steroid, we'll do a second one fairly rapidly, and sometimes we can increase that efficacy to 50 or 60 or even 70%. But in general, these epidural injections are going to be good for that short-term benefit. I can also say that sometimes we'll try these epidurals on people who've had more long-term pathology and more long-term chronic pain. And once in a while, we do get some home runs where people do get an extensive benefit. But in general, for that chronic radicular pain, the epidural steroids are not good for the long-term management. And here's one slide on side effects. So Dr. Chow looked at epidural corticosteroids for essentially epidural type of pain, but they wanted to look at the side effects. So we can see basically a fairly small effect on the pain in this study, but we did have some improvement in disability and decreased chance of surgery. But overall, the most important takeaway here is each epidural glucocorticoid injection increased the 5-year risk of vertebral body fracture by a factor of 1.21. And that's just one independent risk factor of steroids. Of course, we have other infection types of risks. We have osteoporosis risk, as mentioned. We also have hormonal risks and glucose control. So we definitely don't like to inject steroids every 2 or 3 weeks to try to control these pain types of issues. So next, I want to talk a little bit about the facet joint blocks and medial branch blocks. So if you think about the spine, we have the vertebral column in front, and in the back we have basically one facet joint on the left and one facet joint on the right. And these joints get arthritis, they get strains and sprains just like any part of the body. And then when we diagnose this, we can target it in some ways more specifically. One of the thoughts about the facet joint or this type of pain is it generally presents as what we call axial pain. So I think of the facet joints when people have back pain that more or less stays in the back. With the epidurals I talked about previously, I'm really thinking more about a pain that's kind of shooting down the legs a little bit, or shooting down the arms, and the distribution of where that stenosis is. With the facet joints, whether it's the neck or the low back, I'm typically looking for pain that stays in the neck or the low back. When the patients extend their neck or extend their back to activate that joint, we can get a little bit of a radicular pattern, but typically just to the shoulder or to the hip, not anything that really extends all the way down to the toes. And when we have that situation, I like to think of the timing of the injury and the overall pathology. And the way I like to think of it is for younger folks, maybe for some acute trauma or strain type of phenomenon, that's where I'm thinking facet joint injection may make sense, where I can go in and calm down some temporary inflammation and the patient will get better over the course of weeks to months. I like medial branch blocks for the folks who have a bit more chronic pain. So what's the difference? The facet joint injection, I target the joint directly, I target the pathology directly, and I hope it's going to get better over the course of time. When that facet joint is thoroughly degenerated, when I don't really have a target in the joint itself anymore, or if I think whatever is causing the pain is going to persist or get worse, then typically the facet joint injection won't be a great long-term plan, once again, because we don't want to re-inject any body part every 3 weeks or even every 2 months for years and years. So the medial branch is simply the nerve that innervates the facet joint, and each facet joint will have one branch coming from above and one from below. So what we do is we put our needle specifically where that nerve goes, and we put in just a tiny bit of lidocaine, and if the pain gets better for 2, 3, 4 hours from the lidocaine, then we repeat that procedure using the radiofrequency ablation. And as long as we can actually find that nerve with the ablation needle, we should recreate the patient's experience with that medial branch block, meaning relief of that axial back pain, but instead of relief for 4 hours, we're hoping to 6 to 12 months at least. And the duration here typically depends on simply how good that patient is at healing their own nerves. So I think younger, healthier folks tend to regenerate that nerve a bit quicker, and the injection may not last quite as long, whereas my older folks, they seem to get more long-term relief with this. So in terms of the evidence, we do have level 2 evidence. So we have high quality randomized controlled trials for cervical and lumbar medial branch blocks. And if you have a positive block, follow that with the radio frequency ablation. For the actual facet joint injections, we're seeing level 2, 3, and 4 evidence. So a bit more haphazard evidence. And in my mind, I like to think of this more for that acute pain. The overall evidence, if we're looking at the systemic review here, once again in pain physician, is actually level 1 evidence for radio frequency working up to that 6-month mark, and level 2 evidence for the greater than 6-month mark. And once again, I think that's simply a quality of how much nerve are we able to kill with whatever type of procedure we're using that day. And simple things such as needle size and patient status can make a difference there. Cervical, we have 50% relief for 263 days, and 50% of the pain had returned at 8.3 months. So I definitely think of these as being very reasonable long-term chronic pain management options. I don't think 3 months of response after a steroid injection is a great way to go for that long-term management. Here is another review. This is from Cochrane, a little bit older, 2015, looking at the facet joint blocks, and overall they found no good effect of injection of the corticosteroids, and that's on the actual medial branch once again, not in the joint. The steroids do work okay in the joint. And then they noted that the radiofrequency denervation reduced the NRS by 1.5 points at 1 month, but with no long-term effects. They did note decreased disability at 6 months. So why is this? I think there's quite a variability in how people approach these nerves and how they burn them. I don't have it quoted here, but a couple of years ago, there was a study out of Europe called the MINT study that looked at radiofrequency ablation and essentially concluded that, similar to this study, that it wasn't highly successful. But the main issue is simply the large technical variability in how the studies they look at to produce their analysis were done. So for example, if we see the nerve right here that we're going to target, if I go in with a tiny needle that's 5 millimeters and I just put the tip on the nerve here, I can do a technically successful procedure with good stimulation in the operating room. And at the end of that, when I burn, the patient will have some pain relief because I burned a little bit of nerve, but probably it's not going to last for 6 months. However, if I go in with a larger 1 centimeter active tip or a larger gauge needle or a multi-tined needle or even a bipolar approach where I'm burning all of this area, where I'm killing a significant amount of this nerve, that's when we do see those good results up to a year. Moving on, sacroiliac joint, systematic review, once again from pain physician. We have fewer studies looking at the sacroiliac joint, but overall, my sense of the evidence is similar to the facet joint. Typically, with sacroiliac joint pain, it presents a bit like that facet joint pain with it remaining fairly axial, sometimes with radiations down to that lateral hip area. Typically, we approach this for the first time with that intra-articular injection again. And here we see 5 studies showing level 3 evidence, not great, but the benefit lasts up to 3 months. Once again, that seems to be what I see overall with a pretty good response to a steroid injection into a joint that's inflamed. We have 3 studies with periarticular injections. So that's simply instead of trying to guarantee we're intra-articular, the needle may be outside the joint, or we see the medication spread outside the joint. We're seeing short-term relief, 31% at 4 months, which corresponds to what I've been saying. And then once we get to the RFA approach, so here the patients have had not a medial branch block, but a lateral branch block. And if they had a temporary response to that, we do a radiofrequency ablation of the nerves that travel laterally to that sacroiliac joint. And here we're seeing a significant improvement, 50% at 6 months, with a different type of radiofrequency, 71% better at 6 months, and even 48% remained good at the 12-month mark. Here we're seeing the NRS drops down by 2.3. And it's actually maintained at 15 months. So this is pretty fantastic long-term results in the chronic pain world. And we always like to see a reduction in opioid as well, of course. Here is an example of what this kind of looks like. So we have the sacral foramina here. We're imagining that this lateral branch is traveling to the SI joint. So we just try to create a complete lesion using either large radiofrequency probes or multiple types of needles. There's many ways to try to kill and ablate these nerves. Next, I want to talk a little bit about injection of stuff into the intervertebral disc. Mostly, I think, as a research interest, we've tried all kinds of different substances. Even in Omnipaque or simply contrast dye has been shown to be beneficial for some folks. But overall, if you look at the evidence beyond the case series, we don't really have good evidence for contrast local steroids, TNF-alpha, or methylene blue for that intradiscal injection. We saw some hints that people would do better, but overall that didn't really pan out. But it did lead into this regenerative approach to low back pain, which I think is exciting, but maybe not quite ready for prime time in as far as it remains really kind of in the realm of private self-pay. It's not really covered by any of the insurance at this point in time. It tends to be fairly expensive for that. So we do have a systematic review, fairly recent, a couple of years ago, and Pain Physician, looking at PRP initially for intervertebral disc. So in the previous slide, we talked about injecting stuff into the disc. This would be injecting PRP into the disc. So PRP is a platelet-rich plasma, is essentially taking the patient's whole blood and spinning it in a centrifuge and only keeping the yellow portion that has the plasma and the platelets. These platelets will essentially have all of the chemical attractants that our neutrophils will need, that our mesenchymal stem cells will need to go to that area in the body and try to actually create some more disc, more or less, actually regenerate that tissue. The overall conclusion of the systematic review is that the mesenchymal stem cells and PRP may be effective in managing discogenic low back pain, which is what we're talking about here, as well as radicular pain, facet joint pain, and sacroiliac joint pain. Here specifically talking about that PRP into the disc, we actually see here we have 47 patients and we see pretty decent improvement up to 2 months at the 1-year follow-up that was maintained. So that looks different from our steroid injections. Here's a different single injection followed up for 2 years with benefit. Dr. Navani is actually one of our adjunct faculty here at Stanford, and she published this a couple of years ago. Not too many patients, but 14 patients prospective. And amazingly, after the injection, she had 100% of patients with greater than 50% relief at 18 months and 85% of patients at 6 months. Now, I should throw in here one of the caveat with this entire chart is we're not looking at patients with simply axial low back pain. These patients have had that diagnostic injection where a needle was placed into their disc and they responded favorably to a little bit of lidocaine to confirm the pain is coming from that area. And also you do need to have concordant imaging showing that that disc is very likely the cause of that patient's pain. So this is not for just pain in general, this is for just a specific subset of those folks with axial low back pain. And then moving on, we have Akita's paper here, another 14 patients with sustained benefit up to 6 to 12 months. And finally, a little bit larger study from Kirshner and Anitua, 86 patients, that showed at 6 months, 91% of the patients showing an excellent score, 8 and 1% showing moderate or no improvement. Now here, we're going to move over to the MSCs, so mesenchymal stem cells. Whereas the PRP is simply aspirating whole blood and spinning it down, here we are aspirating bone marrow, generally from the hip joint. So a bit more of a painful and involved procedure to obtain the injectate. Here we are looking at injecting the stem cells inside the disc, and we don't see quite as good results as we saw on the previous slide, but we are seeing significant improvement in disability and pain at 3 months and maintained at 6 to 12 months. But only an average of 28% improvement in that pain and disability 1 year after the intervention. One of the slides, or one of the points I really like here is even though the VAS scores were reduced to 22 and 24 at 3 months, which isn't fantastic. VAS scores decreased by 17.5 at 21.9. However, what I find really interesting here is the MRI actually showed that 40% of patients improved radiographically on their MRI. And once again here, we see 10 of 13 patients also radiographically improved on the MRI. So we're seeing that 20, 30, 40% improvement, but we are seeing some actual visual confirmation that that injection actually did do something significant in that patient. Over here, we can see lumbar epidural injections of PRP. So not injecting the disc, we're injecting the epidural space itself. These studies aren't quite as strong as the previous ones, I would say, mostly because they're injecting the PRP along with some local anesthetic, and we do know now that the local anesthetic is fairly toxic to these substances, so it may not be the greatest comparison. Also, here we're giving a little bit of cortisone as well with the injection. But what they found is that they did show a consistent pattern of improvement here, superiority over the triamcinolone group. We're seeing an average modified SANE rating that shows almost 50% improvement up to 24 months. But once again, there was the PRP, but also a little bit of cortisone in there that confuses the issue. Also, a significant amount of these patients were withdrawn, so it's hard to really make any conclusions from this paper. And finally here, Kumar, 20 patients, probably showed the most significant relief and improvement in function with the VAS going from 7 down to 2. 5% of these, 20% of these patients had very short-lived sort of local type of reaction, but not anything significant. And finally, we want to look at facet joint PRP, so targeting that facet joint with PRP instead of the steroids that we looked at earlier. And we're actually seeing that the PRP group does have a bit more long-lasting effect. And in my mind, that makes sense. We know that steroids don't really cure anything or fix anything, and the pain pretty much always returns. However, if we are PRP injecting into one of these early degenerated types of facet joints, maybe we are actually repairing it and causing more long-lasting improvement for that reason. Wu showed that 79% of his 19 patients showed significant improvement at the 3-month mark. And finally, Kirshner and Anitua again showed statistically significant drop at 1, 3, and 6 months after the treatment. So overall, I would say fairly comparable to epidurals, if not better than epidurals. I'm sorry, than just the cortisone injections. So overall, regenerative medicine seems to have pretty good potential. The way I think about it is I like to take my younger patients with maybe a less degenerative type of pathology and try to steer them towards regenerative therapies if that's a possibility. Older patients who tend to have more of a degenerative type of philosophy is where I think maybe the ablation approach may be more durable, but regenerative techniques and what we are injecting for the regenerative approaches is rapidly advancing and improving. I hope it'll be used more over the course of time. Now, one slide briefly on trigger point injections. So this is one easy intervention that you don't necessarily have to be a pain specialist to do, but can be very helpful for that patient with this acute onset or even acute on chronic flare of low back pain or neck pain. I do like to use an ultrasound probe so I can simply target those muscles more specifically, and sometimes I can identify pathology that can be helpful diagnostically. But in essence, if you can palpate a muscle, you can pretty much put a small 25 gauge needle into it and inject a little bit of lidocaine, ropivacaine, or bupivacaine, and generally that patient will feel pretty good, pretty fast. And it's generally not something with a lot of duration. Typically, they feel pretty good from that injection for at least 24 to 48 hours, and sometimes we get a residual effect that lasts for a week or two. So by no means are we curing chronic pain with this, but it can be a procedure to get someone back on their feet or to get them back into physical therapy, to get them to do a little bit of stretching and strengthening, give them some time until whatever caused that spasm gets better on its own. Next, I want to talk a little bit about neuromodulation. Actually has a very ancient history going back to Scribonius Largus in ancient Rome, who found that if you took this torpedo fish and put it in a bathtub and people had a headache, you could just have them stand on the fish in the bathtub, and the electrical shock would essentially help cure their headache. Over the course of time, we've gotten a little bit fancier with technology than the torpedo fish, and now we do have both the peripheral, central, spinal or electrical stimulators, spinal cord stimulators or peripheral nerve stimulators that we use. And of course, the neurosurgeon has brain stimulators that can be helpful for pain as well. In general, we think of neuromodulation for pain more for that chronic neuropathic pain, that complex regional pain syndrome, phantom pain are classic indications. However, over the last 5 years, we've actually had a lot of success in expanding this technology to that axial spine type of pain. So the gate control theory of electrical stimulation by Wall and Melzack in the 1960s essentially says that if you stimulate the A beta fibers out in the periphery, so these fibers are responsible for your regular soft touch, this will essentially overpower the incoming nociception from C fibers and A delta fibers, which are responsible for painful touch. And they'll do this through the use of interneurons at the level of the spinal cord. But the essential thought process is if we can replace that burning, shooting, dull, deep ache of neuropathic pain with the buzzing vibration sensation caused by our electricity, that will do a pretty good job of controlling that patient's pain. The truth is the system is quite a bit more complicated than that, but it works essentially okay for explaining how the devices work. Now, in terms of our choices for neuromodulation, we do have a few. The most basic will be simply a transcutaneous nerve stimulator. This actually works quite well even for that acute low back pain. It replaces heat, it replaces massage, and it actually activates the muscles a little bit. So I think we can get a bit of strengthening. And I do know that when we activate those muscles, we do send action potential back up towards the spine. So there could be some sort of neuromodulation that occurs as well using these types of systems. Now, the next step after that is going to be peripheral field nerve stimulators. And that's going to be using implanted electrodes similar to our spinal cord electrodes, but we're simply putting them in the subcutaneous areas under the skin. This is not anything that's very popular at this point in time. This probably had its heyday around 10 years ago when used in combination with traditional spinal cord stimulators. And that was mostly done because those traditional spinal cord stimulators didn't do a great job of capturing that axial low back pain. Now, next, the advancement of the PFNS has been the peripheral nerve stimulator. So now we are using a lead in the periphery, but instead of simply placing it subcutaneous in the untargeted, undifferentiated area, we are now going to target a deeper structure and more specifically a named nerve. And PNS for low back pain is typically targeting that dorsal ramus that innervates our multifidus muscle. And finally, spinal cord stimulator will of course go in your epidural space or with the spinal cord, and we'll be able to impact all the pain coming from below. So starting off with PNS, this is fairly recent, just for the last couple of years. Dr. Caporal published this in 2018 in Pain Practice. So percutaneous use of PNS for the treatment of chronic low back pain. So essentially the philosophy here is we're catching that spinal nerve coming out. It gives off the dorsal ramus that goes to the transverse process. And here is the medial branch that goes to that facet joint we've been talking about, and also motor branch to the muscle, and there's a lateral branch that's gonna go out. What we're gonna do with the nerve stimulator is essentially look for the branch that's going to the multifidus itself. And we essentially fish around with the needle a little bit until we get very good, strong contraction, motor contraction of that muscle. And in this initial case report, 2 patients, the nerve stimulator was placed with that active motor contraction and left in situ for 1 month. And as we can see, the pain decreased. And what was really interesting is when the treatment was over, the pain stayed decreased. So this was followed with an actual study. So 13 patients, 9 that were taken to 1 year. Here is just an ultrasound image showing what it looks like. Here we can see a little bit of an outline of the multifidus. The needle approach is straight down. Here, once again, we're using the PNS for 1 month and pulling it. And we're seeing that residual effect is persisting for a full 12 months after the treatment is over. So not only are we treating the pain actively by replacing that so-called painful sensation with the buzzing sensation, we're also potentially rehabbing that muscle a little bit by doing these contractions for 1 month. And I also think we're sending a significant amount of normal electricity up that dorsal ramus, up that spinal nerve to the spinal cord, and maybe getting some sort of central plasticity that can explain why we're getting this really long persistent change. And we do see this actually not just with low back pain, with other nerves as well. Now Decker's, this is going to look at a completely different type of approach. This is a permanent type of implant. Once again, targeting that multifidus. And here there's 2 30-minute stimulation sessions per day. And looking
At the active group for the 120 days of the study, we're seeing 65% and 57% reaching the primary endpoint. And in the sham control, they all had the device placed. It just was sub-threshold. We're not seeing the same numbers. However, at this point, we had crossover, and then we can see the sham control can reach the endpoint a bit better. Overall, 64% of patients had greater than 50% improvement, 75% of patients had 30% improvement, and 50% of patients were actually remitters, where their low back pain essentially resolved going down to less than 2.5. And about half the patients eliminated or reduced their opioids. But this is pretty significant improvement in kind of more long-term axial low back pain without having to do a big surgery and without having to even do a spinal cord stimulator and instrument the spinal cord. This is simply activating your lumbar muscles, and over the course of time, patients are getting significantly better. Now, moving up the spine a bit, this is a spinal cord electrode in the actual epidural space. And just briefly summarizing our older paresthesia-based type of spinal cord system data, typically what these older papers show is roughly 50% of people 50% benefit with their pain control. So not fantastic results. It certainly helped a lot of patients, but I certainly had a significant amount of negative trials as well. So these paresthesia-based stimulation systems, essentially that means when we turn the electricity on, the patient does feel that buzzing in the dermatome of where the electrode is located, and we really try to map out and get coverage of where that patient hurts. So using that technology, we see mean relief was 58%. There wasn't any specific predictive patient location or technology that made a difference with this. And most of this was predominantly for leg pain, not necessarily for that back pain. And next, I'll talk more about the newer technologies. So in 2015, the SENSA study came out using a novel high frequency 10 kilohertz type of therapy, and no longer fishing for paresthesias, but simply placing it in a certain location and corresponding to the low back. And we're seeing a significant improvement and benefit since then. So looking at the HF10 therapy, we're seeing around 80% responders versus that 50% in traditional spinal cord stimulation. And if we look at the remitter rate, these are once again the folks whose pain goes down to 2.5 or less, we're still seeing about 70% of remitters in high frequency and around 30% with traditional. And once again, we're carrying this out for 2 years. So very strong results for spinal cord stimulation for even that axial low back pain with more modern technology. And here we can see how our pain scores, RVS, is reduced and is essentially maintained unchanged for the duration of the study. And one more recent type of technology in the spinal cord stimulation field using something called burst, a type of waveform where we're seeing essentially a superiority of burst to that tonic type of paresthesia-based, and most of the patients preferred the burst over paresthesia-based. So my takeaway is I like the TENS more for that acute low back pain type of spasm. I like the PNS for being cheap, minimally invasible, and in some patients providing durable relief. And then I like the spinal cord stimulation more for a bit more intractable pain. And when I do go for the spinal cord stimulator, typically with the newer technology, I can improve my results. So I used to tell my patients 50% chance of getting 50% better, and now I can tell them 80% chance of getting 80% better. And I'm going to close off with just a few slides on surgery for lumbar pain. And I have to be very specific. I'll probably say this a couple of times because I use my surgical colleagues frequently and I refer the patients all the time, is I'm specifically talking about lumbar fusion for pain, only for pain. So 8% of gross domestic product in the United States, $15.68 trillion goes towards musculoskeletal disorders, and back pain is by far the largest proportion here. And spinal fusion ranks first among OR procedures for having the highest cost, and this is for the Healthcare Research and Quality HCUPNet website. It's a federal and state and private kind of combined project website for you can go there and pull up this information for free. But we can see your spinal fusion, $12 billion per year with a mean cost of almost $30,000 per stay. And then we can see going down knee arthroplasty, hip arthroplasty being significantly less costly than that. For example, we're seeing here about $10,000 less on average. And even though there's more, almost twice as many knee replacements, overall the cost is lower than for spinal fusions. So here we're seeing the number of fusions per year has increased 55% from 2005 to 2014, with the ratio increasing in high volume centers from 0.8 to 2.6, and medium volume centers to 2.3, and in low volume centers to 1.5. So overall increasing across the board, across states and across socioeconomic lines as well. So what do we know? It's one of the fastest growing commonly performed surgical procedures. We saw it in the previous slide. And we also know the United States has the highest rate of spine surgery in the world, despite incidence and prevalence rates of spine disorders that are similar to those found in other countries. So we see the rates of fusion going up in all centers, even though we're not seeing any difference in the patient population to more or less account for that. And we do know that historically Americans undergo surgery at a rate higher than persons in other developed countries. But this discectomy rate can actually vary 8-fold, and fusion rate can vary 20-fold, even amongst regions in the United States. So there's a lot of kind of local variability in how many fusions and discectomies are done that can't be explained by any differences in the underlying patient population is the point I want to get to. So an increasing number of complex fusions are not justified by the pathology. So in some regions of the country, surgeons performed as many as 4.6 surgeries, while other regions, they performed only 0.2 per 1,000 enrollees, even though there's not any difference. Now, we also know that surgery is fairly similar to conservative care. For this, I'm going to be very specific and call it benign low back pain. So low back pain without any red flags, without any shooting, radicular pains or numbness or weakness. When we're just talking about low back pain, the physical therapy will essentially be as good as surgery. So here we have 64 patients, and the success rate, according to an independent observer, was 70% after surgery, 76% after the cognitive intervention and an exercise program. Here we have, in one of Dr. Brox's other articles, 60 patients once again. Success rate was 50% in the fusion group, 48% in the cognitive intervention exercise group. In a different group, Dr. Fairbank here, 176 patients showing no significant difference between the treatment groups here as well. But once again, conservative care works really well for this benign low back pain without those red flags, and can certainly be cheaper to the system. And we do know there's no data to indicate that non-surgical management for these herniations or that axial low back pain results in any sort of catastrophic neurologic consequence. A physical therapy approach is very reasonable. However, if we do a bit more, what I like to call the multidisciplinary approach that could come through one of our types of pain clinics, is certainly been shown to be a bit better than just the plain physical therapy. So a graded activity program with a behavioral therapy approach was given under the guidance of a physical therapist, and we show muscle endurance, time, lifting capacity were significantly correlated to return of work, and the traditional care plus the graded activity program were superior to the traditional care only in terms of mobility, strength, as well as fitness. So as we can see, lumbar fusion for non-focal axial low back pain is currently the #1 indication for lumbar fusion surgery, but we don't necessarily have a great kind of physiologic, pathologic reason for why this is. We do know that surgery is definitely indicated in certain cases when you have major trauma, you have instability, spondylolisthesis, clearly if you have infections, and if you have tumors, but most importantly, if you have neurologic deficits. And I do think of that extremely severe 10 out of 10 pain from an acutely herniated disc will more or less fulfill that category as well. But any sort of numbness, tingling going down the feet, any sort of objective weakness, absolutely will require a referral to your surgeon. And of course, any change in bowel or bladder. These are very easy, automatic referrals to your neighborhood neurosurgeon. So not great long-term evidence for any particular treatment. I've shown that the injections do offer short-term benefit, better for this acute type of low back pain. We have to get a little bit fancier with our injections for the chronic low back pain, but we do have different treatments for that as well. Radiofrequency shows moderate benefit. It doesn't cure low back pain because nerves regrow, but we can get pretty good sustained benefit for 6 months or a year at a time. And we have more advanced technologies, both with peripheral nerve stimulation and spinal cord stimulation, that may be a bit more durable than our injections and radiofrequency types of procedures. I touched on regenerative medicine, not quite ready for prime time, but certainly if you have the right patient, send them to someone who performs regenerative medicine for a evaluation. And finally, I made a point that surgery for that axial back pain is not great. And once again, surgery for surgical needs, definitely required. If that patient has neurologic deficit, send them to see a surgeon. But if it's just pain, the surgeon doesn't have a whole lot to offer. And thank you, acutely. I like to think of myself as simply entertaining the patient while they heal on their own, whether I do that with trigger points or acupuncture or physical therapy referral or anything like that. Pretty much they'll feel better in a couple of weeks. If it goes beyond that, consult pain medicine if you're really looking to try to use one of these interventions, not to cure their pain, but to acutely enable them to get back to work, get back to rehab, to go to the physical therapist, to start moving around. And we have this concept of the maintenance interventions for the more chronic folks, where we can help improve their flares, and we can improve their pain situations for 6 months or 12 months at a time. And then finally, we talk quite a bit about when to consult that surgeon for the really severe 10 out of 10 pain, and clearly for the neurologic deficits and for clinically significant MRI findings. Thank you.